Welcome to EM Pulse, bringing research and expert opinion to the bedside.
We're your hosts, Sarah Medeiros
and Julia Magana.
Welcome back to EM Pulse.
Sarah, on a recent shift, I had a teen who came in with recurrent episodes of vomiting, and the resident forgot to ask about marijuana use. I was seeing another patient in the same curtained area and had the pleasure of listening to my patient repeatedly scromiting, and you know what I'm talking about, while I was trying to see my first patient. Sure enough, when I went into the room, the patient was a regular marijuana user. She could not / would not believe that I thought it came from marijuana use. Shocker, I know. Cannabinoid hyperemesis is not new, but it continues to be a thorn in my side. So, to learn more, we are here with our pharmacy colleague, Haley Burhans. Welcome back, Haley.
Excited to be here, and I'm not going to scrum it at you.
That's wonderful for my ears.
Yeah, I have had this patient or patients like her a million times in the ED. Haley, what is your favorite medicine for a patient with this persistent vomiting and abdominal pain that is presumptively due to cannabinoid hyperemesis?
So I think overwhelmingly data over the past couple of years as THCs become legalized, which has allowed us to study it better, Haloperidol or Haldol and topical capsaicin are probably going to be your two first-line agents that should be available in most emergency departments that are a great place to start for symptom control for these patients.
And if you don't have those, what's your backup?
If we don't have those, any dopaminergic agent should be relatively successful for these patients. So if you have Droperidol, that also works similar to Haldol or Haloperidol. Metoclopramide or prochlorperazine can also be helpful, even though the evidence doesn't necessarily stack up. I think the mechanism behind them is worth a try if you have them available.
So you would do Haldol over Droperidol? I'm just curious because I feel like Droperidol is my go-to.
Yeah, I'm not saying one over the other in terms of my own professional perspective, but from a data perspective, I do think the dosing has been studied. So there's the HAVOC trial, HAVOC, where they recommended specific weight-based doses of haloperidol up to a maximum dose. I do think haloperidol can have more EPS side effects compared to droperidol. So I think as a clinician, if in our emergency department people ask me, I say either is worth a try. If you want to do droperidol, that's great. If you want to try haloperidol, that's great. For the most part, we're going to limit these doses. So say for haloperidol, a maximum of 5 milligrams. But as we all know at this table, 5 milligrams can cause EPS side effects for some patients. So I do think droperidol is going to have similar efficacy. There's no reason for me to think that it would be any less effective than haloperidol.
Wait, did the HAVOC trial compare droperidol to Haldol or just Haldol?
Basically looked at haloperidol compared to placebo. So that's why we know that for the specific patient population that there is efficacy in reducing symptoms and reducing their length of stay in the emergency department.
I see. Because I have to say my go-to is also droperidol as well. What dose do you recommend for droperidol?
I think for droperidol, 2.5 milligrams to 5 milligrams is totally reasonable. I think for a lot of patients that are regular adult size, starting with 2.5 milligrams, I would expect to see symptom improvement. So I don't think it's necessary to jump to higher doses of 5 or 10. But if you do have a patient whose symptoms, are very uncontrolled and maybe, IV access is not something that they're totally on board with. And so you think maybe I have this one shot to get one medication in and you want to start with a higher dose. I have no qualms about it. I think it's totally reasonable.
I mean, because I take care of little ones, hopefully not my very smallest ones using a lot of THC, but I usually start with 1.25 or 2.5 for my smaller patients. And I find it to be actually incredibly helpful. What I don't find my patients love is the capsaicin cream. I think I have never had anybody that was like, yes, thank you for putting this on my belly. Tell me your thoughts on that.
Yeah, in fact, I've actually had patients come in and say, I need something and don't give me that pepper cream crap.
Yeah.
Yeah, I mean, I think it's also our nurses would probably agree with that because it is something that literally burns when you apply it to your skin. Or it creates that burning sensation. And then if you happen to touch your face or your mouth or whatever else, it's also going to spread that sensation there. So like if you're vomiting and moving a lot, touching your abdomen or touching the back of your arms is probably going to happen and you do transfer it to other places. So I totally understand from a patient experience, if you already feel crappy, putting hot peppers on your stomach is probably not the best experience. But mechanistically, it does address the pathway that we think causes hyperemesis syndrome. So to me, it's like my second first line. So I would give them Droperidol or Haloperidol if their symptoms persist and they're really just not having a good time. I think it's worth having the conversation to try it. Obviously, we can't give them a hot shower in the emergency department, but that would be even more ideal.
Haley, in terms of the Droperidol, Haldol, can you combine those with an antiemetic, and what kind of dangers do we have there?
Yeah, I think it's totally reasonable, especially, for us in the emergency department. We think we know what's going on, but obviously people can have underlying issues that an antiemetic can be helpful. So antiemetics in terms of, let's just say Zofran or ondansetron, the serotonergic properties aren't going to help hyperemesis, but there can also be something going on in someone who's a chronic THC user. So if you think it's reasonable to use it, I don't have any issues with giving a single dose of an antiemetic with a single dose of a first, butyrophenone like Haldol or Droperidol. But for these patients, as we all know, people that have been vomiting for a long time can have electrolyte abnormalities, which can cause QTC prolongation. So it is something to be aware of, that the additional doses of all these medications can worsen that QT prolongation. So if you have a patient that has other risk factors like heart disease, female, they're bradycardic at baseline, those things are just something to be aware of.
Do you get a baseline EKG on everyone?
I do not, unless they have multiple risk factors. So for me, it's that patient that maybe is on methadone, who also is a chronic THC user, who maybe also has heart failure. And then I start thinking, maybe I should get a baseline and see where we're at, so that when we start giving these medications, we have something to go off of.
Okay, yeah, I totally agree. These patients can vomit until they are severely dehydrated, and the electrolyte abnormalities and acid-base issues continue to astound me, how deranged they can get their electrolytes. Are you a fan of LR or normal saline for these cases?
I think for a lot of patients that we see on their initial lights, their sodium and their chloride are definitely going to be low. So I think starting with NS is totally reasonable. But I think probably best case for these patients is after you give an initial bolus is to find a potassium containing fluid, because we do frequently see that the potassium is low. And as we talked about for the QT prolongation, if they're amenable and we feel like it's appropriate to give them some maintenance fluids, is to just find something with a little bit of potassium in there, which of course LR does have some in there. So if you want to start with that, especially if you do have some information that shows they're hypokalemic already, I think that's also a reasonable place to start.
Yeah, in our case, her potassium was 2.1 and her bicarb had made it all the way down to 11. She was real. What kind of electrolyte issues do you guys run into, and what do you think are some of the best ways to replete them besides just doing IV maintenance fluids?
I think in terms of electrolyte disturbances, low sodium, low chloride, and low potassium are all things we see, especially when people get volume depleted. Your kidneys just can't hang on anymore. And so, as we all know, oral repletion of electrolytes is miserable. And so it's probably not something that you're going to be able to acutely do in the emergency department, or maybe just right when they're ready for discharge. So I think potentially having a plan for your patient of doing some supplementation at home, if they're open to it, may be reasonable if they can't tolerate something IV while they're in the emergency department. But I do think it's a tricky situation, and it's kind of something that maybe just having a plan both ways. IV, maybe a little bit of oral can come together for some full repletion for these patients.
Now, Haley, I've always been taught hypo-K, hypo-MAG. Are you repleting MAG in these patients as well?
I think it's acute. So a lot of times I'm not as worried about it for these patients as opposed to, say, someone that's on like chronic loop diuretics. But because of the potential, worries about QT prolongation, if you do have that patient, remember MAG can sometimes have some cardioprotective effects for patients with prolonged QT. So in those patients, I think it's reasonable to go ahead and do it. But magnesium can also make you uncomfortable if we infuse it too fast, right? So it make you feel hot and flushed. So I think in terms of if potassium's your problem, we know this vomiting's been acute for, 24 to 48 hours. So just go ahead and start with a potassium. That's going to be more important from my perspective.
Okay, let's say the meds work. They want to go home. My kid couldn't go home. But what would you send them home with, and how long would we expect these symptoms to last for?
Yeah, so I think going home, there's actually a decent, which is interesting, sway towards sending home with olanzapine, the dissolving tablets. And I think it's because of the vomiting issue. So if I send you home with like oral Haldol tablets and you swallow them and you throw them up, we're not really getting any efficacy. So I think it's reasonable to send home low dose olanzapine, so like 2.5 milligram ODT tablets. Well, they come in 5 milligrams, but they're very easy to like crack in half like a wafer. Because we can't expect patients to have symptoms persist for a few days and sometimes up to 1 week. So the normal half-life of THC for someone who doesn't frequently use it is 1.3 hours. So out of your system within 5 to 6 hours. For people who use it chronically, it starts to soak up into your adipose tissue or your fat tissue. And you can really saturate that tissue. And for some patients, we've even seen it stay at therapeutic levels for 2 weeks. So giving your patient some coverage for at least up to a week with, say, some oral olanzapine or, some electrolyte supplementation is very reasonable.
I like that as an option. I've actually never done that before, but I always feel like I'm like, oh, it's probably going to come back. Good luck with that, and send with some Zofran or something else like that. So it's good to have that as an option. Is that something you've done, Sarah?
No, I haven't, but I love that. I mean, I think one of the hardest things with this presentation, this illness, is actually trying to have the conversation with the patient about, explaining that this is actually related to their THC use. And it's hard because these are often patients that have been using THC daily for years. And so it's hard for them to understand that, like, why now? How could you think that this is due to my THC? Or my marijuana actually helps my nausea. So, like, why would I not use it now? That can't possibly be it. If you can have that conversation and your patient is open to maybe this is due to THC, how long do they actually have to be off of THC before we can see some effects?
Yeah, I mean, I think the drug can be out of your system, and those pathways that we've activated and upset and caused to be off balance can persist for a long time. And I think, we were just chatting before here. There's a really good paper actually written by our colleagues that goes into some of the pathophysiology that can explain why there's this prolonged effect even when the drug's out of their system. So yeah, I think it's difficult to tell patients that even though you stop taking the drug, you just have to stay consistent with it. And eventually these things will kind of balance out, but they're in it for the long haul.
And if they start up again after 3 months of being clean?
If they start up again after 3 months of being clean, they may not have those symptoms right away. But I think, like we've all seen with chronic THC users, they tend to use more frequently or at higher doses. And so then they will start flirting with coming around to the same problem again with chronic use.
I run into the same thing, Sarah, where a lot of patients are like, no, I've been using this for forever. It makes me better, not worse. You're wrong. I'm right.
Yeah.
And it's very personal for them. And I'm sure that they're using the marijuana for other things that are going on inside of their life that me just telling them to stop taking it doesn't solve. So I understand that it's a complex problem. How do you have that conversation with them, Sarah?
Yeah, so I usually will talk to patients about how marijuana affects your nerves, right? And your neural pathways. And we have nerves and neural pathways throughout our body, in our brain, in our nausea centers of our brain, also in our gut. And while I don't know the exact mechanism that this happens, I try to explain to them that the effect that it is having on their brain can also be having effects elsewhere and can also be having negative effects, and that the long-term chronic use can kind of make this worse. And not everybody will buy into it. Sometimes it takes a few times. I'll often ask them if this has been suggested before, and I validate their feelings. I tell them I know that it's really hard to believe that something you have been using for so long that has been helpful for you could actually be causing these symptoms, but we have lots of data that shows that that's true.
Yeah, I like that. Anything else you think we should talk about today, Haley, on this topic?
I will just say my favorite kind of reference for recapping this topic, you can find the American Journal of Emergency Medicine. It's the GRACE 4 guidelines, which essentially is kind of a descriptive guideline for patients with gastroparesis, cyclic vomiting syndrome, and cannabinoid hyperemesis syndrome. So I think it's a good one because a lot of these presentations can overlap. So it goes into, the presentations and therapies for each of these disease states.
Ooh, we might have to come back and do some more podcasts on those other topics.
Haley, thank you so much for sharing your wisdom with us. And thank you to our department for learning ways to treat this well.
And thank you to OM Productions for not being a scrometer.
So until next time, stay curious, stay inspired, and stay tuned.
The opinions expressed on this podcast are those of the hosts or guests and do not necessarily reflect the views of UC Davis Department of Emergency Medicine, UC Davis Health, or their parent organizations.